Welcome to Prenatal Care 101. My name is Christina Gracie, and I'm the Women's Health Education Director for the Family Medicine Residency Program. The slides here are graciously provided by Sarah Shields and her colleagues as they presented for the American Academy of Family Physicians. The slides are adapted with additional slides added for prenatal care teaching in the Worcester Family Medicine Residency Program, with the purpose of these slides being used to teach. These will not be shared outside of the residency program. Additionally, at the end of this presentation, there will be SDFM RCR cases that you will go through with 4 specific forms that you'll need to complete in order to complete this process. For our learning objectives for the first half of this program, we will be asking you to think about evidence-based prenatal care prevention and management strategies for concerns common to the first 20 weeks of gestation for women with routine and high-risk pregnancies. We want you to develop shared management prenatal strategies that encourage patient adherence to medical recommendations. This is a large topic that would be presented in a comprehensive way in a conference like what Sarah Shields did with her colleagues. When we think about the goals of prenatal care and the places to find guidelines, the options for the structure of prenatal care, and then the critical nature of cases that allow us to discuss content, we'll go through a lot of that today in order to help prepare you to take care of our prenatal patients in the outpatient setting, and then ultimately in the inpatient setting as well. We want you to be able to think about accurate dating, physical exams at intakes, nausea and vomiting, common screening tests, including tests like a urine culture, Rh status, and anemia. We want you to be able to think about chemoprophylaxis. We want you to think about nutrition, obesity, and then we're not going to talk about genetics, but it is important to learn about genetics as you go through your residency. In the second half of this presentation, you'll learn about evidence-based prenatal care prevention and management strategies for concerns common to the second half of pregnancy, and specifically focus on a set of cases there. We'll also want you there to develop shared management prenatal care strategies that encourage patient adherence to medical recommendations, and then be able to develop an outline of steps towards preparing for childbirth, including antenatal fetal surveillance.
The goals of prenatal care are not only to determine the due date and estimate a gestational age, but also to assess risk, medical, obstetrical, and social, at all stages of pregnancy, with an ongoing evaluation. We want to anticipate and intervene where appropriate in problems, in hopes of reducing maternal and infant morbidity and mortality. We want to really focus on health promotion, supporting a patient and her family, engaging her in decision-making, shared decision-making, and educating so that we can help her prepare to parent. We want to think about partner involvement. Who is the ideal person to support this patient during her pregnancy? Does she have what she needs?
The typical prenatal care timeline really starts before 8 weeks gestation. Maybe even starts before a patient becomes pregnant. If they're planning to become pregnant, we can help guide them in their decision-making as to best prepare their bodies for their pregnancy. We want to think about all the different factors that come into play during pregnancy and what we need to do as physicians as we counsel our patients on what needs to be done. In the early course of the pregnancy, before 14 weeks gestation or in the first trimester, we think about dates, teratogens, genetics, vaccinations, medications. We want to counsel about risk-taking, do some motivational counseling to help change behaviors where needed. We want to think in the 16 to 24 week mark about prematurity prevention, cervical insufficiency, and genetic screening for those patients who desire it. Later in pregnancy, between 25 and 28 weeks, we think about screening labs. We think about looking for intrauterine growth restriction, preeclampsia, and then this is also where we start thinking about including our obstetrical colleagues who can do tubal and VBAC consults in addition to our family medicine obstetrical colleagues. A little bit later on in the third trimester, we think about breech. We need to think about C-sections and if those are indicated for patients, and then we need to think about GBS screening. Finally, as we approach 41 weeks, we need to think about the post-term time frame and when we may want to recommend an induction of labor, if not prior to 41 weeks.
What women want in prenatal care is to have a positive pregnancy experience. We want to maintain physical and sociocultural normality, a positive pregnancy for mom and baby, including preventing and treating risks, avoiding illness and death, and helping patients transition effectively to positive labor and birth experiences. We want to achieve positive motherhood, including promoting maternal self-esteem, competence, and autonomy. And we can do this through many different means, including ideal clinical practices, interventions, and acting on tests appropriately, providing patients with relevant and timely information, and supporting them both psychosocially and emotionally. We want to make sure that we are practitioners who have good clinical and interpersonal skills, and that we provide the highest level care within a high-quality health system.
In terms of prenatal visits and what method, the standard pattern is to basically start around 8 weeks and go every 4 weeks until the 30-week mark, at which point the visits transition to every 2 weeks from 32 weeks until 36 weeks, with weekly thereafter until the post-dates period. The WHO recommendation is that there is a minimum of 8 contacts. When studied, reduced versus traditional numbers of visits, essentially there's no difference in maternal mortality, preterm birth, or SGA. However, women may be less satisfied with fewer visits. In terms of group versus individual visits, there are many practices that utilize group prenatal visits. And essentially, there's patient satisfaction that's similar between groups with no difference in the rates of preterm birth, low birth weight, perinatal mortality, or breastfeeding. The pandemic brought in new possibilities, including telehealth, for prenatal care, which is a reasonable option if the patient can basically provide the information they would have been able to provide in the office, including their blood pressure and their weight. It's helpful to think about the group care ACOG guidelines. Group prenatal care models are really designed to improve patient education and include opportunities for social support while maintaining the risk screening and physical assessment of individual prenatal care. Studies do show that there are high levels of patient satisfaction and that the obstetrical outcomes are as efficacious as individual prenatal care, with some improved outcomes for some populations. So ideally, you offer this to your patients if it is available to you in your facility. There are some wonderful prenatal care guidelines that are out there, including the guidelines for perinatal care, which is a collaboration between the American College of OBGYN and the American Academy of Pediatrics. There are also excellent American Academy of Family Physician resources and multiple other guidelines that can be utilized to guide your decision making with patients, including the USPSTF guidelines, the CDC guidelines, the WHO, and the NICE guidelines. We'll refer to many of these during the presentation.
As far as counseling is concerned, we want to explore our patients' perceptions and normalize common complaints in pregnancy. We want to explore a woman and a family member's perspective as it relates to fears, ideas, function, and expectations. We'll talk about the mnemonic FIFE in the second half of this presentation. Motivational counseling is important. We want to help patients avoid teratogens, drugs, radiation, and hot tubs. We want to help them make sure that they're wearing their seatbelts correctly. For example, the lower part of the seatbelt low on the hips and the upper part of the seatbelt in a diagonal across the chest wall. We want to help them avoid occupational and environmental exposures. Think about infection risk for things like toxoplasmosis with the cat litter or listeria when consuming raw dairy, and help them avoid both cleaning the cat litter as well as consuming dairy products like raw dairy products. We want to help them think about healthy lifestyle choices and recommended weight gain, continuing to exercise and focusing on nutrition, making sure patients are not eating for two, and we want to think about promoting avoidance of anything that could cause harm in the growing fetus, like tobacco or alcohol. And lastly, we want to help them with anticipatory guidance as it relates to pregnancy-related issues.
Okay, so we're going to start with talking about due dates here. We want to think about the different OB wheels that are available, including the OB Wheels app from Josh Steinberg, which is available for both iPhones and Androids. I want you to think about a case where a woman is going to be due, but you don't know exactly when she's going to be due. Remember that the traditional way of calculating due dates depends upon a regular 28-day cycle with the expectation that a woman likely ovulates in the middle of her cycle. But remember, this is really variable, which makes it hard sometimes to figure out when is a patient actually due. So we're going to talk about some specific questions to help us understand how to come up with a due date. So for example, based upon the information you have, when do you expect the patient is going to be due? So Maria comes to you for prenatal care on February 1st, 2021. She uses a menstrual tracking app and she's able to check that she recorded her last menstrual period as December 5th, 2020. You pull out your app and you calculate her estimated due date as September 11th, 2021. And she is now 8 weeks and 2 days. What other questions might you ask to help determine her estimated due date? Think about her period. What is her normal period? Does she get them every 28 days? When would she expect to get her period? What were her prior menses like? Were they regular, irregular? What's the usual cycle duration for her? Has she been on any hormonal birth control? And does Maria need an ultrasound for dating? So early ultrasonography should be performed if the patient has irregular cycles or bleeding, if the patient has unknown or undetermined timing of her last menstrual period, or if there's a discrepancy in the size of the uterus compared to gestational age. These are the prior guidelines that really most people used in order to think about whether or not an ultrasound was needed. Ultrasounds were also considered if a higher risk pregnancy was at play, where planned induction of labor or C-section or preterm labor was an issue. The American College of OB/GYN uses the first trimester sonogram as the most accurate method for gestational age. If a woman has not had a gestational age measured by sonogram before 22 weeks, we are considered to have suboptimally dated her pregnancy. The chart on the right helps us think about the known accuracy of sonographic criteria for dating the ultrasound versus the last menstrual period, and helps us think about whether or not we want to change a woman's due date based upon the ultrasound. The ACOG bulletin here specifically notes that the ultrasound measurement of the embryo or fetus in the first trimester up to and including 13 and 6 weeks gestation is the most accurate method to establish or confirm gestational age. In terms of thinking about the language around dating, we want to think about the estimated due date in one of the following ways. So if somebody says that the estimated due date is based on the LMP alone, that implies that no ultrasound was done. If the estimated due date is based upon X number of weeks gestation via ultrasound, then we think that the estimated due date is determined by the ultrasound. And lastly, if the LMP is consistent with X week ultrasound or inconsistent with X week ultrasound, that would be considered the most ideal way. The standard of care really is to list the dating method and then the inconsistency or consistency with the other dating type. So for example, a 13-week ultrasound inconsistent with an LMP, or LMP consistent with a 13-week ultrasound. Maria's first visit in the office could look like many different options. You could certainly have a single long visit that's physician driven. You could do a single long visit that's divided between a nurse and a physician. You could think about doing 2 visits, a nurse intake with labs ordered and then a physician visit to follow, usually in the same week. Sometimes people think about doing a single visit and then do an early dating ultrasound in the office at the same time. Typically, we do early dating ultrasounds at the 8 to 10 week mark, and those can be done at some health centers. Team-based care is critical in prenatal care. Usually we combine nurses and PAs, NPs, and physicians all working together in a model that allows for most comprehensive approaches to care. In some models, there's a first visit with a nurse or a PA and or an NP, and then a second visit where there's a nurse also involved for counseling, but perhaps there's a physician who places orders or a PA or an NP who does the same. And then we think later on about the 3rd trimester where we have, again, a similar team-based model. Okay, so this patient's here for the first prenatal exam, and you want to think about, what does she really need? Does she need a breast exam, a complete physical? It's really hard to know. You know, in family medicine, we're already caring for these women before they become pregnant, so they might have just had a recent physical. We want to think about whether or not they need another vaginal exam if they had one of recent, especially if they have a history of trauma. And at the same time, there might be some specific things that we need to detect during pregnancy that we wouldn't have examined otherwise, and think about murmurs or thyroid nodules that could impact the pregnancy. So routine pelvic exam may or may not be necessary. The NICE guidelines suggest that the pelvic exam is not necessary, and breast exams may not be necessary either. Complete physical, is that necessary? Well, which parts? What if they haven't had any prior care? What if you don't know anything about their physical status? Well, certainly a physical exam could bring you new insights. There are 4 types of preventative interventions that we think about during pregnancy. 1, immunization. So we want to think about, is this person up to date on their immunizations? That could impact the baby, not just the mom. Screening tests, chemoprophylaxis or procedures, prenatal education, and behavior change counseling. So let's talk about labs. Which of the following tests do you routinely get on every pregnant woman at her first trimester visit? You should go ahead and think about those for a moment. So which screening labs do you actually need at the first visit? So the USPSTF A and B recommendations can be helpful here. A recommendations include HIV screening, cervical cancer screening if the patient's due, but if they're not due, they don't actually need to have this done. And if they really wish to have it deferred until after they are done with the pregnancy, that is also a reasonable option. But remember, that can put a patient behind in terms of intervention if they needed to have their abnormal pap smear intervened upon. In terms of hepatitis B surface antigen, that is a class A recommendation, syphilis screening, asymptomatic bacteria, Rh antigen testing, and then class B recommendations include gonorrhea and chlamydia, rubella immunity, and most recently, grade B recommendation from the CDC is to screen all pregnant women for hepatitis C. You can review the USPSTF Task Force guidelines on the link at the bottom of this slide. There are some USPSTF D and I recommendations. For example, D, we say don't do it. Harms are greater than benefits. Bacteriovaginosis screening in asymptomatic low-risk women, screening for lead in pregnant women, and herpes serology in asymptomatic women are grade D recommendations. Grade I recommendations, where there's insufficient evidence, include iron deficiency screening, tobacco cessation with pharmacologic use in pregnant women, suicide risk evaluation, bacterial vaginosis in women at high risk of preterm birth, and screening for illicit drug use. So let's go back to the tests that you want to routinely get on every pregnant woman. HIV, hepatitis C, pap smear, urine chlamydia. You can also do this with the cervical swab, but it is not necessary to do so. Hepatitis B surface antigen, complete blood count, urine culture to screen for asymptomatic bacteria, Rh antigen, antibody screen, so that goes with your type and screen, rubella, and syphilis. Syphilis is a 2-part screen.
Please refer to the USPSTF screening guidelines as it relates to syphilis in pregnant women, noting that there is a 2-step process in the case where a patient does have an initial positive screen.
Whether or not to screen for anemia in pregnancy is an interesting topic. The USPSTF grade I recommendation is that there's insufficient evidence to screen. However, other sources do recommend screening, including the CDC and guidelines for perinatal care. You do want to test for a diagnosis of anemia if you're concerned that a patient may have anemia. For example, if they eat a low amount of red meat and are suffering with palpitations, it is very reasonable to screen that patient for iron deficiency anemia.
Micronutrient supplementation is an oral tablet that contains the recommended daily allowance of multiple vitamins and minerals, including vitamin A, B1, B2, niacin, B6, B12, folic acid, vitamin C, vitamin D, vitamin E, iron, copper, selenium, and zinc. We do recommend, according to multiple guidelines, micronutrient supplementation for all pregnant women. There is some data to say that the micronutrient supplementation or prenatal vitamin decreases the risk for neonatal mortality in low-income or home birth countries, and, per Cochrane Review, reduces SGA and low birth weight. In terms of high-income countries where women in the United States may lack iron, vitamin D, and folate in the diet, this micronutrient supplementation remains important.
You do want to think about extra folate for some women. So for example, a person who has a past history of a child with a neural tube defect should take 4,000 micrograms or 4 milligrams of folate preconception and then early in pregnancy, not just the 400 micrograms. Women who take folic acid antagonists should also have to think about the higher dose. So those who are on trimethoprim or anti-epileptic agents should really be on 4 milligrams of folate. Obese women may have a higher risk of neural tube defects as well, but it's unclear if the higher dose actually prevents this. This is one of the ACOG bulletin snapshots that helps us think about the risks of neural tube defects and the supplementation recommendations, including 4 milligrams of folic acid daily. Initiate this 3 months prior to pregnancy and continue this up until 12 weeks of gestational age. And then you can read the additional rest of the guideline online as to understand the additional subtleties of this. We're going to talk about thyroid testing now. Are you screening all pregnant women for thyroid disease at intake? Well, there's a lot of variation on whether or not this is done. Remember, it can be normal for the thyroid to get larger in pregnancy, and the TSH can be low in the first trimester, and the free T4 can be a bit high without the woman actually having hyperthyroidism. And so it's really important to think about whether or not you need to test somebody for thyroid disease. Certainly if they have a prior history of thyroid disease, then that would warrant going ahead and testing. But for most patients, the TSH is not evaluated in the first trimester. So we're going to talk about Maria. Remember her? So she had a sister who was with treated hypothyroidism. Maria wants to know if she should be tested too. There are some observational studies suggesting subclinical hypothyroidism is associated with neurocognitive development issues. Universal screening is really not recommended at this point, but if symptoms or history do warrant doing so, testing is appropriate. This is a case that's going to help us think a little bit about hemoglobinopathies. So let's say that Lan is a 27-year-old from Cambodia who's seeing you for the first prenatal visit. What additional testing do you want to offer? The California data set here helps us think about the annual incidence of thalassemia, 1 in 1,000 among Asian births. Beta thalassemia and also hemoglobin E and hemoglobin H are more commonly present in certain populations. Hemoglobin H is the second most common hemoglobinopathy detected by newborn screening.
It's helpful to think about a flowchart for screening when we think about hemoglobinopathies in pregnancy. In the UK, Europe, and Canada, people universally screen more readily than in the United States. In the US, it is important to think about screening for patients and think about the backgrounds for these patients in order to understand possible hemoglobinopathy risk. You can also look at the CBC where the MCV may be low, or you may see hypochromia in the findings on the red blood cells, an MCH less than 27 with an elevated red blood cell count. And you also may be able to think about some thalassemia mutations or structural variants and the effects of those on your blood counts.
All right, we're going to move on to RH status. So let's talk about RH testing in pregnancy. Remember, Maria is 8 weeks pregnant at the time of her first visit. She reports spotting last week after her home pregnancy test was positive. Her initial labs show her to be A negative, antibody negative. What do you suggest?
The American College of OBGYN has put together a set of guidelines regarding the use of RhoGAM in any setting that could cause feto-maternal transfusion, and thus the mother can develop maternal antibodies to Rh-positive red blood cells. Some common reasons to give RhoGAM to an Rh-negative mother include spontaneous or induced abortion or threatened miscarriage. This does depend upon the gestational age. There are some groups that do not recommend giving RhoGAM prophylactically in the cases of spontaneous complete miscarriage before 12 weeks of gestation if the uterus was not instrumented. Additional reasons to give RhoGAM to an Rh-negative mother include significant abdominal trauma, amniocentesis or chorionic villus sampling, ectopic pregnancy. We do give this routinely at 28 weeks to Rh-negative mothers and then routinely within 3 days after delivery of an Rh-positive infant. Now we're going to talk about other screening in pregnancy. USPSTF A and B recommendations. Tobacco use screening with behavioral interventions is considered a Grade A recommendation. Grade B recommendations include screening for depression, screening for sexually transmitted infection behavioral counseling, alcohol misuse, and intimate partner violence. One could make the case that we should really be screening all of our patients for intimate partner violence as well as depression, and our practices here at UMass are to do so. Let's talk about the smoking history for Maria. So we know that the USPSTF Grade A recommendation is to do a tobacco screen and behavioral intervention. The 5 A's include asking, advising, assessing, assisting, and arranging. So you don't want to necessarily ask just, do you smoke, but have you ever smoked? And some women may have actually just recently quit and may be at higher risk for smoking again. We can think about the resources available to us, including the 1-800-QUIT-NOW National Quit Line and the successful implementation of clinical preventive service resource, which is available through the AHRQ. The American College of OBGYN has a committee opinion on smoking cessation in pregnancy. Currently, the USPSTF has a Grade I level of recommendation regarding the benefits and harms of nicotine replacement products or other pharmaceuticals or smoking cessation aids during pregnancy. Many of us do use these with our patients, depending upon the patient. It's helpful to think about the different kind of interventions that may exist for patients and whether or not for a particular individual nicotine replacement may be beneficial. Bupropion has limited data but is probably safe. There are some psychiatric effects that need to be considered. So essentially, the American College of OBGYN has said that we can use nicotine replacement products in consultations with experienced providers, and family medicine doctors often feel comfortable using nicotine replacement products in pregnancy. Next, we're going to talk about Maria's BMI, which is 40. What other kind of screening tests do we want to offer to her at her first visit, and what is the plan for her pregnancy? So we want to think about early screening for diabetes during pregnancy. The American College of OBGYN, in collaboration with the USPSTF, recommends screening for overt diabetes early in pregnancy in those who are at higher risk. There is a UMass guideline that we have available that is in the MCH shared drive that can help you with all of the decision-making around screening for diabetes. We want to think about patients who are at higher risk, for example, those with a previous history of gestational diabetes, obesity, or known glucose intolerance, and screen for diabetes in those patients using an A1C or fasting blood glucose levels. When it comes to taking care of pregnant women who struggle with obesity, we want to think about compassionate care and think about the different risks that can come with it while being very careful about the language that we use. Here are some resources that can be available and helpful to you in thinking about how to best manage obesity in pregnancy. As far as the recommended weight gain, there are some specific numbers that can be helpful, and they are listed here on the table. These numbers can help guide whether or not a patient is in the ideal range for weight gain during their pregnancy, depending upon where they start for their initial BMI. As far as the maternal weight gain recommendations, there's no change based upon race or ethnicity, and the Institute of Medicine recommends not differentiating between classes of obesity. Gaining more than the recommended amount of weight, regardless of pre-pregnancy BMI, is associated with gestational diabetes, operative delivery, as well as shoulder dystocia. So when we think about our patient, we're going to go and imagine what it looks like for her if she feels unwell. She's 9 weeks along, she's vomiting every day. and in particular in the morning, sometimes more during the rest of the day, and she's nauseated all the time. She feels lightheaded. She's worried she's lost weight since her last menstrual period. You check her office records and notice that she is actually down 5 pounds. What do you think could be helpful for her? Nausea and vomiting of pregnancy is common. Risk factors include multiple gestation, molar pregnancy, nausea and vomiting in a prior pregnancy, motion sickness, family history, and a female fetus. What other red flags might we want to think about for further evaluation and other diagnoses? So normally we wouldn't expect to see patients with abdominal pain or tenderness. We wouldn't expect to see neurologic findings. We wouldn't expect to see a goiter of the thyroid. Most commonly, patients suffer with hyperemesis for benign reasons, but when the hyperemesis gravidarum develops, that is, they develop intractable vomiting, they start to develop weight loss, electrolyte, thyroid, and liver abnormalities. They have a large amount of ketones in their urine. We start to worry more about these patients. It's less common than just nausea and vomiting of pregnancy or occasional times when people vomit for a morning. Instead, this is a persistent kind of problem and the second most common reason for hospitalization. It's helpful to think about a scoring system that can be useful. So the modified pregnancy unique quantification of emesis and nausea is a validated tool that can be used to think about the risk for hyperemesis gravidarum in a pregnant patient. This particular score has 3 questions, which is essentially a Likert scale of 1 to 5 on frequency. Reads, on average in a day, how often do you feel nauseated, vomit, retch without vomiting? And the score under 6 is considered mild, 7 to 12 is moderate, and greater than or equal to 13 is considered severe. This can help you think about how much is this problem affecting a patient's quality of life. So in terms of different ways that we can help prevent this, well, we can think about prenatal vitamins. That actually does reduce the incidence and severity of nausea and vomiting. Frequent nutritional meals every 1 to 2 hours, in particular, avoiding a full stomach, avoiding spicy or fatty foods, avoiding iron, for example, just taking the folic acid can be beneficial. Although for patients with anemia, this could create an additional set of challenges. We want to recommend to patients that they eat right when they awaken, that is to eat something. High protein snacks may be even more helpful than carbs, although often for the first meal of the morning or the first snack in the morning, carbohydrates can help relieve some of the nausea and get some food down, which is beneficial for nutrition and for helping patients start to feel a little bit better. Treatment approaches include ginger. We can think about acupuncture. Early treatment can actually help prevent progression. So B6, generally in doses of 25 milligrams with doxylamine, 25 milligrams in combination 3 times a day, is the general approach that many physicians take to help patients prevent the progression from initial mild nausea and vomiting to a more severe kind of persistent pattern. You can add other medications like diphenhydramine. We can add compazine. We can add Reglan. These medications, including Zofran, can be helpful. We do have some recent data saying that the cleft lip and palate and cardiac risks do exist with the medication Zofran. However, in general, people still feel very comfortable using this medication in pregnancy. Rehydration, so getting patients early IV fluids and considering the use of steroids can be additionally helpful for patients as they're trying to manage their nausea and vomiting of pregnancy. So, for example, getting a patient into the outpatient setting for 1 liter of fluids, management of the nausea can help keep them out of the hospital and then essentially make sure that they're well enough that they can go home. I added a management algorithm for the treatment of nausea and vomiting of pregnancy here. I know you can't see all of the fine detail, but essentially in UpToDate, there's a useful algorithm that can help guide when you want to take the next step in managing a patient's condition. All right, we're going to move on to surgical history. So we want to think about bariatric surgery. This is not that common. We see this, but when a patient has had a history of bariatric surgery, you do want to think about that. How does bariatric surgery change your screening and counseling? So general thoughts. After initial weight loss, fertility is often increased. So that's important to know. We want to know if the patient had type 2 diabetes prior to losing weight, and then obviously rescreen them for diabetes during the early part of their pregnancy. For many years, surgeons have recommended delaying pregnancy for about a year to a year and a half after bariatric surgery. But really there have not been complications for mothers and babies generally found when people are studied on a wider scale. So essentially, you're going to be following the recommendations that the other people with bypass and other malabsorptive surgeries would follow. Additional recommendations after bariatric surgery include early screening for gestational diabetes. Patients may not tolerate the 50-gram glucola secondary to dumping. An alternative would be 1 week of daily fasting and 1 hour postprandial glucose measures at home. Serial growth ultrasound and consultation with maternal fetal medicine is actually recommended. Long-acting oral medications like nifedipine have irregular and decreased absorption, and that's important to know too if a patient develops hypertension and needs treatment. Next, we're going to move into thinking about a case where the early prenatal care actually depends upon a woman's past obstetrical history. We want to think about interventions that can reduce her risk and that can be initiated in the early part of her pregnancy. So your nurse is getting a patient's history during her OB intake visit. Janet is a 32-year-old G2P1, and at the end of her pregnancy, 5 years ago, she had transient hypertension. Last year, during her annual checkup and at follow-up, you diagnosed her with hypertension that initially required a thiazide diuretic for control. She stopped the medication when her home pregnancy test was positive. Her intake blood pressure was 138/84, and she is asymptomatic. What are you thinking about for additional testing and treatment for Janet during this pregnancy? The USPSTF recommends the use of aspirin, 81 milligrams, low dose, as preventative medication after 12 weeks of gestation in women who are at high risk for preeclampsia. The studies have shown that the number needed to treat depends upon the amount of high risk. So, for example, the benefit is greatest in certain populations, those with preeclampsia, IUGR, and preterm birth. As far as how long to take the medication, well, no studies have been really used before 12 weeks, but the NICE recommendations are until delivery. So who's at high risk for preeclampsia? Well, it depends upon what guideline you use. So the NICE guidelines actually determine that high risk is considered those with hypertensive disease during or prior to pregnancy, chronic kidney disease, autoimmune disease, type 1 or type 2 diabetes, chronic hypertension. And then if one or more of the following risks is present, a patient is also considered high risk. So first, pregnancy, age greater than or equal to 40, greater than 10-year pregnancy interval, BMI greater than 35, and family history of preeclampsia or multiple pregnancy. Of course, you can see here that the WHO or the USPSTF recommendations are actually different. While we're on the topic of thinking about preeclampsia, we can talk about chronic hypertension. So when a patient comes in and they have chronic hypertension, so they have known elevated blood pressures from the past, you want to actually go ahead and order baseline lab studies on that day. And this kind of information, as well as additional information, is in the shared drive as it relates to the UMass guidelines for management of patients with hypertensive disorders of pregnancy or patients with chronic hypertension. The very first time you see these patients, you want to do a urine protein assessment. So that's a urine protein to creatinine ratio. That's not a microalbumin to creatinine. It's a different kind of test. You want to order a baseline creatinine and AST and ALT, as well as a CBC that allows you to look for platelet count. You want to think about accurate dating. Make sure a patient gets an early dating ultrasound early. That'll help you figure out for comparison later on, whether or not a patient is growing an appropriately sized fetus. You want to think about more visits for blood pressure monitoring. Definitely think about getting a patient a blood pressure monitor for home as well. And there are some studies that actually show patients with low calcium intake have a higher risk for preeclampsia. So go ahead and think about whether or not calcium is something you want to prescribe and talk about that with your attending. All right, now we're going to move on to talk about all the things that you need to be able to remember. So, how are we going to remember to do certain things at certain times? Well, certain tests need to be done by certain gestational ages. So, for example, the first trimester aneuploidy screen has to be done by 13 weeks. Not all patients will want that, but making sure that for the patients who want it, it's done by that time frame is essential. The quad screen has to be done by 15 to 22 weeks, the dating ultrasound in the first trimester, so before 12 weeks, and then the anatomy scan by 20 weeks. The ROGAM and 1 hour glucola is done at or shortly thereafter, 28 weeks, and the GBS swab is done between 35 to 37 weeks in the oldest recommendation, and the newest one, it's 36 to 38 weeks. So you can use your EMR paper reminders to make sure that these things happen at these times, and OB review at each site also is a way to get this done. So as far as auditing is concerned, some specific practices have a practice of auditing charts at 24, 30, and 38 weeks. And at the Family Health Center of Worcester, that's what is done to send the chart to the hospital. It's a little bit easier probably at practices where the Epic system is already up and running. And so we can use Epic to generate reports, and those reports can be used as part of a monthly process at each site to review the panel of patients and make sure that the appropriate labs have been ordered and different interventions have been done for a patient. Best practice recommendations include having a checklist approach to prenatal care to remind you about certain counseling or testing in various parts of the pregnancy. You want to offer group visits and other changes to standard prenatal care. So think about expanding your team to include people like your nurses or your advanced practitioners to help you. Expert recommendations include the USPSTF guidelines for perinatal care and NICE guidelines, and these different kind of recommendations will help you develop your screening tools and practices. Incorporate non-laboratory screening for risk factors. So think about smoking, depression, violence, and substance use. Be thorough as you ask your questions about obstetrical history, past medical history, and past surgical history. Look for specific risks like preterm birth, hypertension, and bariatric surgery. And remember, you are essential in helping your patient become most comfortable and most healthy during their prenatal course. You will also become essential in caring for the newborn. Now we're going to move on to the second half of the presentation, focusing on a different set of issues. We're going to focus on evidence-based prenatal care prevention and management strategies for concerns common to the second half of pregnancy. We're going to talk about cases. We're going to develop some shared management prenatal care strategies that encourage patient adherence to medical recommendations. We're also going to talk about how to prepare patients for childbirth, and we'll talk about antenatal fetal surveillance. This is a huge topic, so it's important to remember that you may have questions and you can always turn to me for those or to your faculty colleagues at your specific health center. So as far as the goals of prenatal care, we of course want to think about the due date and assessing risk, ongoing evaluation, anticipation and intervention for problems, and we want to help patients prepare for what is required for parenting. So we're going to talk about a case of a woman who is a 17-year-old G1. She's 28 weeks pregnant, and essentially, other than being a teen, she had an uncomplicated pregnancy. Your medical assistant notes that the EMR says she's due for influenza, a second HPV, and hepatitis B vaccine. What would you like to give her today? Immunizations given during pregnancy are a way to protect not only the mother, but also the people around her and her growing infant. 27 to 35 weeks in each pregnancy, we want to give the Tdap vaccine. There's really a need as well for other people in the family to get this vaccine. So siblings, fathers, grandparents, child care providers, and healthcare workers all really should be getting this Tdap vaccine that will help protect the mother and her baby. So there's no increased risk of reaction if another tetanus is given within the past 2 years. So essentially, you want to go ahead and give this every single pregnancy, every single time. You don't need to repeat this if it was given in earlier trimesters. So for example, if a patient happened to get the vaccine at 26 weeks, and typically we'd give it at 28 weeks, you don't need to give it again. You shouldn't give it again at 28 weeks, but ideally you give it at the 28-week mark in pregnancy. The influenza vaccine is really important. So this vaccine is essentially an inactivated influenza vaccine, safe in any trimester. You can also use any of the antivirals that we use to treat influenza. Those are safe for pregnancy. And really, we want to think about Tamiflu as the preferred treatment. It's a 5-day course. You want to think about post-exposure chemoprophylaxis for 7 days after the last known exposure if a patient is pregnant and exposed to an individual with influenza. And as far as hospital guidelines regarding isolation of the newborn, those would vary depending upon the hospital and each year. So important to check on the hospital guidelines regarding isolation of a newborn in case the patient does develop influenza during her pregnancy. And this will be the same thing as it relates to COVID. Patient who has COVID, the isolation of her newborn would depend a lot on the hospital guidelines related to this. Most hospitals do not isolate a newborn if a mother has influenza or COVID, but instead works to keep the mother from transmitting infection to that newborn by mask wearing and other hygiene practices. So as far as the influenza vaccine in pregnancy, about half of women get vaccinated. Of course, the vaccine is about 60% effective in many seasons, including that season listed here. And up to 80% of women think that vaccines actually cause birth defects. So there's a lot of education that we do related to vaccines that can be helpful for women. Hospitalization rates for pregnant women are actually similar to elderly patients, which is key. And newborns are actually, more protected as a result of mothers getting the influenza vaccine. So we want to really tout the benefits of mothers getting influenza vaccine during pregnancy. Immunizations are an important part of prevention. So we can start the hepatitis B series at the first prenatal visit. Hepatitis B vaccine is safe in pregnancy. HPV vaccine, however, is not recommended because there's little safety data. We avoid live attenuated vaccines in pregnancy. So the MMR, for example, FluMist, varicella, or Zostavax all are contraindicated. And of course, this is a theoretical set of risks, but still important to follow the recommendations. All right, so now we're going to talk about travel. So let's say that Amy, she's traveling back to their home country of Vietnam for the coming year. What would you recommend for Amy as she's pregnant? What other travel advice do you want to consider? So travel medicine for pregnancy. Safe vaccines include hepatitis A, probably the encephalitis vaccine, probably the rabies vaccine. It's not that these are contraindicated. We just generally don't have these questions come up. But if a patient really feels strongly that they be vaccinated against Japanese encephalitis or rabies, you can actually go ahead and vaccinate them. IPV vaccine is okay if needed, although, again, there's no real data to drive this. Safe medications include anti-malarial medications and medications for a traveler's diarrhea. Some antibiotics are not safe in pregnancy, for example, Cipro, so you have to be thoughtful about which medications you prescribe for antibiotics in the case of GI illnesses. Pregnancy-specific precautions include helping patients think about their risk for DVTs. For example, getting on a plane, being sedentary for long periods of time in combination with pregnancy puts those patients at higher risk for DVT. You want to counsel them against, ignoring any kind of warning signs. So any kind of leg pain or swelling would be a warning sign for a DVT and would make a person need to get evaluated. We want to think about having patients bring a copy of records to wherever they're going so that they have those records for cross-coverage purposes for other clinicians. Next, we're going to talk about diabetes screening. So basically, the USPSTF and ACOG guidelines are that patients should be screened for gestational diabetes. The USPSTF guidelines are that patients should be screened for gestational diabetes regardless of symptoms after 24 weeks of gestation. There is a beautiful UMass guideline that we have in the share drive that can help you think about screening for diabetes, as mentioned prior. The ACOG guidelines are that all pregnant women should be screened for gestational diabetes, whether by patient's medical history, clinical risk factors, or lab screening to determine blood glucose levels. We generally want to do that screening at the 24 to 28 week mark, and most people do use the 1 hour glucose testing as their initial screen. The NICE guidelines essentially have people assessing for risk of gestational diabetes by essentially considering BMI above 30, previous baby that was greater than 4.5 kilograms, previous gestational diabetes, first-degree relatives with diabetes, minority ethnic family origin with a high prevalence of diabetes, and essentially all of those women would get offered testing for gestational diabetes. Our screening is more universal and not risk-based here in the United States. So what if somebody has a history of gestational diabetes? This is Paula. She's a 32-year-old with a history of diet-controlled gestational diabetes. She's in her first pregnancy and here at 10 weeks for her first visit. What extra screening do you want to consider for her? So if you use the NICE guidelines, you would screen at the first visit for diabetes if there's a prior history of gestational diabetes. You would think about an early self-monitoring of blood glucose, a 75-gram 2-hour oral glucola test, and then repeating that testing at 24 to 28 weeks if the first testing was normal. Now, the ACOG and ADA guidelines are different. We want to screen for overt diabetes at the first visit if there are risk factors, including a prior history of gestational diabetes, body mass index greater than 30, or a known impaired glucose tolerance. You want to really think about at UMass using the UMass clinical guidelines that are in the shared drive. That'll be helpful for guiding what to do as you think about screening for diabetes. So, in the shared folder, and I did have a snapshot here on the bottom right, you can see that there are guidelines related to obesity, hypertension, gestational diabetes, and HIV, as well as the trial of labor after cesarean. So go ahead and refer to those gestational diabetes clinical guidelines. For the first visit screening that we typically do at UMass, we think about early glucola testing at 12 to 14 weeks to really avoid issues earlier than that in terms of giving patients too high of a sugar load and them feeling more nauseous and vomiting early in pregnancy. You can actually do screening earlier than this with an A1C or a fasting glucose. You still, of course, want to go ahead and repeat your testing generally between 24 and 28 weeks. And that would, of course, be if the first testing was normal. So what about 1 hour or 2 hour glucola testing? So the 1 hour 50-gram glucola test is not fasting. You don't want patients to be carbo loading, but at the same time, it's fine if they have had anything to eat in the day other than a heavy load of carbohydrates. The threshold for diagnosis of diabetes is really interesting. So 130, if you cut it off at 130, patients, will have a higher risk of false positivity, and you'll essentially, miss fewer cases. If you cut the number off at 140, you're going to miss more. But at the same time, the most high risk women may be still identified with a lower false positive rate. So there's no clear evidence that support a cutoff of 135 versus 140 for the 1 hour glucola screening test. So just select a single consistent cutoff for your practice and then go from there. So ask this question when you're working with your patients at your clinic, of your faculty and figure out what the right cutoff is. Sometimes if I have a patient who's right on the border, say they have a measure of 136, I'll go ahead and follow up with the 3 hour testing because they are too close to that border of 140 even for me to feel comfortable letting them go on the pregnancy without additional testing. Universally, some people use the 75-gram 2 hour oral glucola test, but really we don't do that at UMass and that wouldn't be considered the standard of care at UMass. So what if Amy's 1 hour glucola is 150? What do you do next? So you want to think about the 3 hour glucola test, which should be fasting. There should be no smoking, drinking, eating, or exercise during the testing. If the 1 hour test comes back and it's over 200, don't go ahead and move forward with the additional 100-gram load. Instead, you want to bring the patient in for a fasting measure. If it's greater than 95, then she has gestational diabetes, and you can use the clinical guidelines to determine your next steps. If it's less than 95, you could consider proceeding with a 3 hour glucola test, or you can treat empirically for gestational diabetes. And again, use those UMass guidelines. Those will be helpful in figuring out your next steps. All right, now we're going to ask some questions about STI rescreening. So Kayla is a 22-year-old G2P1. She's diagnosed with chlamydia at her OB intake. She and her partner were both treated for chlamydia. Her HIV and syphilis IgG at intake were negative. Should she be retested for STIs and when? So basically, you want to repeat STI screening in pregnancy for test of cure. So the USPSTF guidelines are essentially to repeat the testing after 3 weeks and then repeat again in 3 months. You want to think about, you can use any kind of treatment, urine, cervical, or self-collected. And then the urine for chlamydia should be first voided, not clean catch. The third trimester repeat screening is of consideration as well. You can consider HIV, syphilis testing at the 28-week labs, or GC and chlamydia at 36 weeks with the GPS testing. You can think about using rapid HIV testing in labor, and we do have UMass clinical guidelines around HIV management at UMass. Okay, and then what about screening in pregnancy otherwise? So we talked a little bit earlier about some of the screening, as it relates to tobacco and depression and alcohol misuse. As far as the STI behavioral counseling, post-test counseling is an integral part of managing patients who have a newly diagnosed STI. So safe sex practices can, of course, reduce the risk for disease transmission or reinfection. And so you want to help patients think about how they can engage in less risky behaviors. High intensity interventions, that is, those that last greater than 2 hours, are more effective in reducing STIs than low intensity ones. But don't forget that even a shorter discussion with one of your healthcare team members may be beneficial in reducing the risk that a patient would get reinfected with a sexually transmitted infection. You want to, of course, take a good sexual history with any patient. We want to think about patients who are higher risk for sexually transmitted infections, including those patients who have a new sex partner, more than one sex partner, if they are in relationships where patients have known sexually transmitted infections, patients are exchanging sex for money or drugs, and think about higher risk STI cases among incarcerated populations, military recruits, and patients who are getting care at public STI clinics. There are some racial and ethnic differences that are important to recognize as well. All right, we're going to move on to GBS, so group B strep. So we'll talk about a case. Valerie is a G2P1 who had GBS detected at 35 weeks in her first pregnancy. She was treated in labor and thankfully had no complications. Which of the following is true? So 1, she doesn't need any rescreening. She should be considered a carrier in this pregnancy and treated in labor. 2, even if she had GBS detected in her 12-week urine culture, she still needs a repeat test, the rectal vaginal culture at 36 to 37 and 6 weeks gestation. 3, if she had anaphylaxis to penicillin, you should order clindamycin, erythromycin susceptibility testing when you order her GBS culture at 36 to 37.6 weeks gestation. And then lastly, self-collection of GBS culture is not a good option as compared to the provider collection. So it's really helpful to think about why we do any kind of GBS testing. So the American College of OBGYNs has a beautiful committee opinion that essentially replaces the older guidelines, and this helps us think about when we should do screening and why we do it. GBS disease can be a major problem for infants, including term infants. There's a 6% mortality risk in term infants and a 20 to 30% mortality risk in preterm infants. There's a waxing and waning nature to the carriage of the GBS load in the rectovaginal area in mothers. If a patient has a urine culture that's positive for GBS anytime in pregnancy, you treat in labor, but you don't go ahead and repeat any kind of testing later after the initial urine culture, you can assume that the patient needs GBS prophylaxis in labor. Treating with this, we'll talk about in a little while. If a patient has a known history of penicillin allergy, you want to be very thoughtful about notating that and getting sensitivities at the time that they get the rectovaginal swab. This is going to help you determine which antibiotic you will use for that load of GBS bacteria during labor. As far as prior GBS colonization, you do want to think about retesting patients. So just because a patient has GBS positivity in one pregnancy does not mean they will have it in a second. But if you have a patient who has a prior infant who is affected with GBS sepsis, you don't retest. You just go ahead and treat that patient, assuming that their GBS prophylaxis is necessary. There's actually very good data for self-collection of swabs, so you can let patients self-collect. You just want to give them specific instructions on how to do so. Now, if the initial test is done before 36 weeks and the patient is now, say, over 41 weeks gestation, you can go ahead and retest that patient for GBS. Now, what if no GBS result is present because the patient had no local prenatal care? You want to basically use the algorithms described prior and treat if there are risk factors alone. Now we're going to talk about hepatitis C. So Amy's aunt has hepatitis C, and she's asking if Amy should be screened during pregnancy. So basically at this point, this slide doesn't describe the most specific recommendation, which is basically to screen all pregnant patients for hepatitis C. The other approach that we used to take was much more risk-based. How about hepatitis B in pregnancy? So this is definitely something we screen for. Here's a case. Rosalind is a 24-year-old G1 from Brazil. Her initial labs show her to be hepatitis B surface antigen positive. What other testing do you want to do? As far as monitoring treatment of hepatitis B in pregnancy, the prevalence is less than 1% for chronic hepatitis B viral infection among U.S. pregnant women, but greater than 25,000 infants are at risk for a chronic infection born annually to these women. Screening and the vaccine at birth in the newborn have helped reduce but not eliminate transmission. So when a patient has known hepatitis B infection, you want to go ahead and get some labs. ALT, hepatitis B E antigen, hepatitis B viral DNA load, and essentially this load will help you figure out whether or not you want to give treatment. Amnio and CVS is okay if the viral load is high, although there is some risk for transmission when the process of amniocentesis or CVS occurs. Routine C-section is not needed, and breastfeeding is okay after giving the immunoglobulin. Okay, how about fetal growth? You've been seeing Amy for prenatal care for the rest of her third trimester. At 28 weeks, her fundal height is 26. What do you do? And what about at 30 weeks? If her fundal height is still 26, what do you do? So fundal height measurements are notoriously subjective. Depends a lot on where you go ahead and put that measurement tape, and the continuity and experience of the measurer matters. If the difference between the expected fundal height and that is measured is greater than or equal to 3 centimeters, we do recommend an ultrasound. So Amy's ultrasound at 31 weeks demonstrates that the baby is at the 15th percentile for estimated fetal weight. What other information might you want? For example, an amniotic fluid index that helps you figure out the amount of fluid around the baby, Dopplers, a biophysical profile. All of these can be very helpful. So what is your plan as you see that the patient is at the 15th percentile for estimated fetal weight? There are multiple options for antenatal testing, including a non-stress test, a modified biophysical profile, which is a non-stress test and an amniotic fluid index, biophysical profile, and a contraction stress test. Some form of testing is recommended in the third trimester for women with particular conditions, including gestational diabetes on medications, hypertension, IUGR, thyroid disease, and post-dates. Depending upon the person who orders the test, there may be some variation in which option would be preferred. And as far as the modified biophysical profile, that's really used most of the time. We want to think about the immediate evaluation of fetal well-being, which is the NST, and the evaluation of uteroplacental function, AFI, as being critical ways in which we can understand how a fetus is doing and how the placenta is functioning, respectively. An AFI is a measurement that is taken via ultrasound that you will learn how to do in this residency. The old way of measuring was basically by always using the sum of the depth of pockets in all 4 quadrants. There is a new way that we sometimes use, which is to use the deepest vertical pocket as a way to figure out if the fluid level is overall appropriate. Today, we do use both, and most patients will get a measurement of a complete sum of all the 4 quadrants, as well as the designation of a deepest vertical pocket. If the AFI is less than or equal to 5 centimeters, that's considered low fluid and oligohydramnios, and would be important to do serial antenatal testing for a patient with this finding. All right, now we're going to move on to a patient who has a cold. So Kathy is a 25-year-old G2P1. She's 24 weeks along. She's caught a bad cold from her 2-year-old son. She's coughing and congested. She can't sleep. She wants to know what she can take. What do you suggest? And how do you think about medication safety? Where do you go to find out about medications in pregnancy? Medications in pregnancy. So when we think about pregnant women, 90% of pregnant women take one prescription medication. Less than 10% of medications have a whole lot of information associated with them to know that they're safe. Some common medications taken generally include acetaminophen, antibiotics, ibuprofen, pseudoephedrine, herbal remedies, and antidepressants. The FDA pregnancy and lactation labeling rule is helpful to know about. This essentially has required that all prescription drugs have the letter categories removed. So instead of being designated to have a pregnancy category C, now all new labels have to essentially be registered with the Pregnancy Exposure Registry, have a risk summary, and data and clinical considerations associated with their labels. The fetal risk summary is useful in terms of designating the likelihood of specific abnormalities, structural abnormalities, embryo fetal infant mortality, functional impairment, or impaired growth. If you look at every medication in UpToDate or in the resource that you most prefer, you will see this labeling information, and this can help you figure out if a medication is safe for a patient based upon what you know about that patient and that particular medication. This just shows the difference between the labeling before 2015 and the labeling that's been in effect of recent. This is a list of resources for medication information that you may wish to use as you help guide patients around whether or not to take medications. All right, so as far as Kathy's cold is concerned, the good news is she's past the first trimester. So the higher risk period of the first trimester is one in which we need to be extra careful about medications. For her, now that she's in the second trimester, we can think about saline, normal saline, and sinus irrigation, diphenhydramine, which does have some oxytocin effect, but is generally considered safe in pregnancy, acetaminophen, and we can think about dextromethorphan. We want to avoid pseudoephedrine, and we want to think about avoiding guaifenesin and NSAIDs in the third trimester. Limited data around echinacea and zinc tell us that these medications are probably safe. These over-the-counter herbal supplements are probably safe. All right, what about patients who are late to care? So Amy returns from Vietnam with her cousin, and she says that she's due with her first child in 2 months. She wants to get prenatal care with you. What do you do the same or differently when seeing her for the first time in the third trimester for prenatal care? What are your office's guidelines? Should you consult or refer? This is a patient who's late to care. So first, I think you want to consider holistic care. You want to focus on things like safety, housing, substance use. You want to focus on where are we with this patient's overall status. You want to think about dating. So this patient may not have had an ultrasound yet. You want to assess growth. Ideally, she would have had a first trimester ultrasound and then a second ultrasound to assess growth. But if you're working with a third trimester ultrasound, the dating is going to be less accurate than if you had a first or a second trimester ultrasound. So that may guide some of the decision making at the end as it relates to things like induction of care. You want to think about woman-centered family medicine, maternity care, and really wraparound services like behavioral health services and other kind of support services that may be necessary for a patient who didn't get the ideal levels of care earlier in pregnancy, perhaps for specific reasons. We're going to move on to breast or bottle feeding. So Lori's here at 24 weeks. She has an uncomplicated pregnancy so far. You haven't yet asked her about breastfeeding. You didn't get a chance, but what do you say now? What's the most important intervention you can do to increase Lori's chances of breastfeeding as long as possible? The USPSTF recommendations for breastfeeding include providing interventions during pregnancy and after birth to support breastfeeding. This is a grade B evidence recommendation. And essentially, we have shown that by intervening and talking with patients and supporting them as it relates to breastfeeding, increases the duration of time for which patients breastfeed. Some interventions to promote initiation of breastfeeding include healthcare professional-led breastfeeding education and support. Antenatal education alone does not do it. However, helping patients before, during, and after they deliver is essential to supporting them and ensuring that they have what they need to be skilled in breastfeeding. Here's a great slide that has a link on it in the center. I want you to watch this WHO educational video on how to support women with breastfeeding and how to think about the anatomy as it relates to both mom and baby in order to help educate a mother and help her breastfeed most easily. When we're in the second half of pregnancy, we want to consider whether a patient is smoking, using alcohol or drugs, and get them appropriate support and treatment. If there is a concern about nutrition, we want to continue to address nutritional needs. We want to think about safety of seatbelts. Are they being worn properly? Exercise. Is the patient continuing to exercise in moderation, exercising too much or too little? We think about preparation for labor and connecting patients to childbirth education, including hospital resources where appropriate. I want to think about preparation for the newborn. So how is the parent preparing for the newborn, and what kind of support might be needed to help educate a patient around what it takes to care for a newborn? Contraception. If a patient's planning to use contraception after delivery, that's important to know and to ensure that the patient's aware of all the different options. We want to think about fertility awareness. Is the patient aware of when she may be more or less fertile? As far as the C's of late pregnancy, we want to evaluate if the patient is vertex. We want to do that through both Leopold's and an ultrasound in the office and make sure we understand if the patient is vertex. Circumcision. Is the parent planning on a circumcision for the baby, and do they know what that would entail? Car seat. We want to think about if there's a car seat already set up in the car and available, or if a car seat needs to be obtained for the parent. They need to go into the hospital with the car seat in the car in order to be able to leave with the baby. Caregiver. Are the parents prepared for the delivery, and are there additional support people planning to take care of the newborn? Calories. So as far as whether or not a parent is planning to breastfeed or bottle feed, that can help guide some of the discussion around what kind of calories may be needed after delivery for the parent. And then mother, we want to think about contractions, help counsel her and know that if her contractions become more frequent, for example, every 3 to 5 minutes, she really needs to call us and let us know that that's going on. Cervix, we want her to know the cervix will dilate, and when it dilates, it's often crampy, uncomfortable, there may be some bleeding. She may rupture her membranes. You want to tell her that she could rupture her membranes. That could happen in any place, and if that occurs, she needs to come to the hospital, well, ideally notifying us that she's coming. We want her to think about care and labor. Does she have support people? Does she want a doula? Can we organize her systems for her and with her in order to best support her? We want to collaborate. If there's a desire for the patient to have a birth plan, how can we utilize that birth plan to communicate with the other team members, like the nurses, about what's important to this patient? And then finally, coping in labor. We want patients to have some sense of what they might want for pain control and have an understanding of that before they come in. Lastly, we want our patients to describe to us if they have any preferences for their labor. For example, if they want to have a female only in their care, we want to be mindful of where to communicate that information and to help counsel her on what kind of setup we have in the hospital. We want her to be able to have control over her circumstances and also to understand what kind of different limitations we may have in our system. Woman-centered care late in pregnancy involves using the mnemonic FIFE, fears, feelings, ideas, function, and expectations. The third trimester visits are more frequent and are opportunities to discuss issues. For example, with feelings, what helps you most when you worry about labor? Ideas, what was your mother's or other important maternal figures' experience of pregnancy and birth? Function, how are you coping at work or at home as your body changes? Expectations, as we get closer to the due date, what are you expecting about when you will go into labor? And what has helped you get through painful or difficult situations in your past? Okay, now we're going to talk about birth plans. How do birth plans affect birth outcomes? So I'll ask you the question and I'll let you read. What do you think of each of these statements, and what's the evidence? So birth plans, the evidence. So based upon a 2010 survey, 65% of medical personnel versus 2.4% of patients believe that patients with birth plans had overall worse obstetrical outcomes than patients without a birth plan. A large retrospective cohort study from LA showed that the likelihood of vaginal delivery for women who attended birth education classes, had a birth plan, or both was actually higher. Smaller prospective cohort study by the same group showed no difference in delivery type between women who presented to labor and delivery with or without a birth plan. Women with a birth plan actually had fewer intrapartum obstetrical interventions, including oxytocin augmentation, and there was no difference in the use of intravenous analgesia, but significantly less epidural use in the birth plan group. Women with a birth plan were actually less satisfied with their birth experience than those without. Birth plans are really a great way to have a conversation. They offer a unique opportunity for providers to engage women in shared decision making early in their prenatal period and to discuss expectations, fears, gaps in knowledge, and specific decision points that may impact a woman's risk of cesarean. Here is a useful birth preferences guide that you can use to help provide your patients with some examples of what they could use if they wish to have a birth plan. Here are some sample birth plans as well that you could use if desired to help guide a patient in developing their own. Best practice recommendations include vaccinating in pregnancy, flu, Tdap, and Hep B especially. Offer early gestational diabetes screening to at-risk women and rescreen at 24 to 28 weeks if the initial testing is normal. We want to screen all pregnant patients for gestational diabetes at 24 to 28 weeks regardless of risk. Choose a gestational diabetes screening test and cutoffs that are specific to your clinic. Most patients will get the cutoff of 130 or 140, but please check in with your faculty when looking at the lab results. If you find one STI, screen for the rest and vaccinate against hepatitis B. Think about behavioral counseling as critical for patients who are diagnosed with an STI. Treating hepatitis B in pregnancy is safe for women with a high viral load. Hepatitis C screening is now recommended for all women. Breastfeeding counseling prenatally does improve breastfeeding rates, and it's really important to look at the particular patient with whom you're working and recognize that they may have preferences, and without asking them what their preferences may be, it may be hard to know whether or not they wish to breastfeed. Using a woman-centered counseling approach is really critical in family-centered maternity care. Encouraging women to consider developing a birth plan may be appropriate, and helping a patient by actually specifically supporting them around developing a birth plan if they desire to develop one is key. Use family medicine, maternity care, and motivational interviewing strategies. You are critical in helping prepare your patient for an ideal experience in the hospital. Next, you're going to move on to the prenatal care modules. So essentially, the goal is to ensure that you are prepared to provide prenatal care before seeing patients in the health center. Some learning objectives are listed here. Essentially, you will have a set of modules. These will include covering preconception, or first trimester, second trimester, and third trimester topics. You're ready now to initiate the prenatal care modules. There's the preconception and first trimester one, the second trimester, and the third trimester one. There are 5 Google Forms that you will complete, and upon completion of these, this information will go to the rotation director, who will review and let you know that all of them are complete, with additional feedback provided to you as needed. So each of the evaluations will relate to the topics that were presented in the modules, with the final evaluation being of a case JJ. So go forward, let me know if you have any questions, and I look forward to seeing your forms and providing feedback to you. Thank you very much for your time, and we are so appreciative of the care that you provide to our patients.